Okay, so we've seen quite a few challenging and interesting cases. This is a bit different than what you've seen so far. This is something that, uh, as far as EUSFNA is concerned, there's a service that is very popular and very common to do in Shaukat Khanam, being a tertiary care cancer center. And I think it's one of the very few places, actually, I think the other one is Aga Khan. Besides that, I'm not sure if Shifa does that. Dr. Nadra is here. You do. So I think we're like the three centers that this happens. This is our data with regards to the pediatric population and our experience with the USFNA in the pediatric patients. We've had many publications with regards to adults. We've shown our sensitivity and our specificity and our adequacy rates and how we do it with regards to rapid on-site evaluation and all. But as far as pediatric population, this is our first experience that we're putting out. It's going to be putting out for publication pretty soon. Uh, uh, Pediatric FNAs, they've been common. They've become very common during the last decade or so around the world. I think overall, US FNA has been in existence since 1980s. But as far as pediatric EUS FNAs, they were not that common and they just became very popular almost about 10, 15 years back. And we've been doing them as well. So this is in the picture, you can see the main Shaukat Khanam building in Lahore. And at the bottom, you can see the new sign that we have along with the Joint Commission. That's the Enterprise Accreditation. And very proud to say that Shaukat Khanam was the second hospital in the world to achieve that thing. So that's an amazing feat that we are all very proud of. Okay, so I'll start with a case. This was a 10-year-old male, and there's a history of Hodgkin's lymphoma on cervical lymph node biopsy. It was a stage 1 disease that was in the initial workup. Now the patient presents with enlarged celiac axis lymph nodes, multiple, and this was following one cycle of chemotherapy for Hodgkin's. There was clinical suspicion of disease progression to stage 3 now. So the CT-guided FNA was not possible, so it was decided that we'll go ahead and perform the US FNA. So this is the first picture. This is a diff-quick 10x history of Hodgkin's lymphoma. Any takers on this? Sorry? Possible, yeah, granulomatous inflammation, but then granulomatous inflammation can be associated with Hodgkin's, with other lymphoproliferative processes. So some higher picture, yeah, more granulomas, right? Epithelioid histiocytes with some lot of inflammatory cells in the background, eosinophils, lymphocytes. Again, there's some small collection of epithelioid histiocytes. Even further on 40x, you can see more epithelioid histiocytes here. So what is this here? So but is this really something that is very clear-cut sign of Hodgkin's or an RSL? Do you see any other cells that look like those binucleated or mononucleated cells? You sometimes get mononucleated cells as well post-therapy, isn't it? The majority are granulomatous or the collection of epithelioid histiocytes forming nice granulomas. I did not see any other cells like that. And this was actually called this is another picture on the pap stain. So more epithelioid histiocytes, actually tons of them, right? Anything suspicious on this? Here? So again, it's all collection of epithelioid histiocytes. This was called granulomatous inflammation cultures were done, and they confirmed that this was MTB. So it helped patient from being upstaged and being radically treated, obviously, because they just put him on anti-tuberculous drugs and the patient was fine. This was most likely secondary to the chemotherapy or many other issues with regards to immunocompromised status and all that this patient got the TB and developed granulomatous inflammation. Anyway, so let's talk about EUSFNA. This was just a case to start you off with. EUSFNA, we just learned from Dr. Ali, so I'm not going to go into details of what it is really. It's an endoscope, and then there's an ultrasound attached to the end, and you're in a very close proximity to the lesion, and you can do the FNA using a 22 gauge needle, mostly. And then you have a cytopathologist. Gastroenterologist is performing that. You have a cytopathologist sitting there or by the site to do the rapid on-site evaluation, or ROSE as we call it. We can make cell block if it is required, or if the diagnosis can be done on smears, then you can just say that we don't need a cell block. Or if you think that in the case that we just saw, that if you need culture material for granulomatous inflammation, or if you're suspecting fungus, then you can request that as well. In addition to that, you can always request ancillary studies for flow cytometries, immunohistochemistry on cell blocks, so multiple other things that can be done. So the importance of presence of cytopathologist over there with rapid on-site evaluation and then any further studies that need to be done is why with EUSFNA you need to have a cytopathologist in the suite while the endoscopy is being done, and when the smear is made, it needs to be evaluated right there and then for any further for adequacy analysis, as well as any further studies that need to happen on that. So EUSFNA is a minimally invasive procedure. It's a day case procedure. It's diagnostic, not only diagnostic, as well as it could be therapeutic. There could be cysts that could be aspirated and the cyst would collapse and that the patient would be treated, and it has happened. We've seen that happen. No extensive preparation is required. It's faster, it's cost effective. And again, with rapid on-site evaluation and ROSE, it increases the yield and outcome of the whole procedure and the diagnosis. So like I said, for the pediatric patients, EUSFNA for adults has been there since 1980s, but really for pediatric patients, it became very popular during the last decade or so, for last 10, 15 years. Mainly because initially it was thought that smaller equipment is required, tolerance of procedure issues, many other issues that were thought of, and that's why it didn't become very popular. But now more and more pediatric patients, especially those with cancer and suspected relapses and all, they're being subjected to EUSFNA, so that, especially for those in which you can't do the image-guided procedures like CT-guided procedures and all. This is one of the major studies that I came across. There's a combination of 19 articles. The data had 571 pediatric patients, and the majority of the indication for this in this study for the EUSFNA procedure was pancreatic biliary disease, including the cysts, stones, neoplasms, and they had an adequacy rate of greater than 95% in their study, sensitivity of 87%. And almost 100% specificity. And definitive diagnosis was rendered in about 82% of the cases. And some major complication that they came across was bleeding, and that really is one of the major complications of EUSFNA, even in adults. So how it really happens, the patient presents to the clinic with symptoms, CT, abdomen, chest, pelvis, depending on where the symptoms are done to identify where the lesion is. And then the patient is scheduled for EUSFNA, especially for those who can't have a CT-guided or radiological biopsies, like pancreatic lesions or celiac axis nodes, or areas where it's very difficult to access under radiological guidance. It is scheduled, and the gastroenterologist performs the procedure. Cytopathologist is there to do rapid on-site evaluation on DIFQuick. Very important to have the DIFQuick stain, because a lot of labs that we've come across, they do it on H&E stains. It's not the ideal stain, and it should not be done. It has to be done on DiffQuick to come to a real conclusion and to have a good diagnosis. All right, so once the DiffQuick is done, then the material is collected for the PAP stain and for the cell block material for final diagnosis. And for those, if you require any immunohistochemical stains, obviously the cell block is there. If you require flow cytometry, you collect the material for flow cytometry. If you require cultures, you collect the material for cultures. And eventually the final diagnosis comes out, and the management plan is based on the cytological diagnosis. So few studies or few diagnoses which are done on cytopathology, and the eventual management is done on that. Okay, so our experience with regards to pediatric patients. So we collected data from 2005 to 2022. So this is the time that really we've been doing EUSFNA at Shaukat Khanum, 17 years. The inclusion criteria is obviously they had to be pediatric patients. They were in-house patients, like we had all the details of them when they came in, what was done to them, their demographic details, their follow-up details, everything was available, radiology. All the things were available in our HIS system. And I must say that our HIS system is one system with everything incorporated, from radiology to all the clinical notes, to the pathology, to the demographic details, to the finance, to the administration. Everything is part of one system, and I've not seen any system like that. I've worked around the world, and it's really a beautiful system to have, and it's an in-house developed system. So we have that information available, and that was one of the inclusion criteria, and eventually successful completion of the EUSFNA procedure. And the key points that we looked upon in these patients that we included in our study, that we had the demographic details, we evaluated that, what was the indication of the procedure, the site of the procedure. We looked upon the adequacy rates. We looked on what was done on rapid on-site evaluation and what was the final diagnosis. And then obviously the stats, and that basically meant the specificity, the sensitivity and all. So we had about 64 patients who had an adequate sample with cell block material, and the adequacy rate that we had was 86%. So 64 patients, and 55 of them had this adequate materials. Average number of passes that we had was 2.17, and this is something that is really an average that we've seen in many studies. I'm going to show you a comparison of various studies, and these are the number of passes that is average pretty much all around the world. There were 22 females and 42 males, and the average age was 12.4 years. The major indication for EUSFNA were mainly for our population was enlarged lymph nodes in 81% of them, followed by pancreatic mass or a paraesophageal mass. So majority were mainly for enlarged lymph nodes, and these were mainly cancer patients where we were following them up for suspected recurrence of disease. Right, and the most common site for the lymph nodes was subcarinal node, followed by pancreas and celiac axis lymph nodes. The most common diagnosis that we had was Hodgkin's lymphoma in about 27% of the cases, followed by granulomas in about 18.6%, and then reactive lymph nodes in about 16% of the cases. So 70% of the cases had the cell block available. We utilized cell block for ancillary studies, immunohistochemical stains in about 22% of the cases, and the rest of the diagnoses were made on smears. So we did not really need any immunohistochemical stains or flow cytometry or anything for those studies. The sensitivity of the procedure for these pediatric patients was 76.5%, 96.3% specificity. There were peculiar findings besides the lymph nodes. Like I said, 81% or almost 82% were the lymph nodes. There were 3 cases of solid pseudopapillary tumors in these children, 2 cases of recurrent Wilms tumor, and there was 1 case of metastatic rhabdo and neuroendocrine tumor each. Now, this is the comparison of our data with the one that I just showed, the biggest global review, and then there's one Indian cities that I found. And as far as the number of patients included in this study for Shaukat Khanum, As you can see, I showed 64 patients. The biggest one had 571 patients. The adequacy rate for our study was 86%, which was quite comparable to the one in an Indian population. But this was for the global review that they had, and this was 95%. Overall, there was a combination of 19 studies that they evaluated. The main indication for the Shaukat Khanum study was for enlarged lymph nodes, like I said, 82% almost. For the other two studies, it was pancreatic biliary or pancreatic lesions. The mean age was 12.5 years for both the studies at Shaukat Khanum as well as the large review, whereas for the Indian study, it was about 15 years. For our study, the most common site was subcarinal lymph nodes, and then for the other two studies, it was pancreas. Our sensitivity was 76.5%, whereas for the reviews that they had, it was 87% and 88% for the Indian study. And similarly, for the specificity, it was close for both the Shaukat Khanum and the Indian study, whereas it was almost 100% for the review that they did for the 19 studies. So these are the two references that I'm talking about. The first one was a pediatric population EUS ultrasound and a comprehensive review of literature, and the other one was a diagnostic utility of EUS guided tissue acquisition in children. And this was again a tertiary care cancer center in India. So let's look at some of the cases that I have here from those pediatric population. So one we just saw, the granuloma. This is an 8-year-old male with a history of Hodgkin's lymphoma now, again, like the first case. This now presents with enlarged subcarinal lymph node, and EUS FNA was performed. All right. What is it here now? So multiple different types of cells in the background. There are some eosinophils here. And then there are these cells here. Any granulomas? Better? Some eosinophils in the background, other different inflammatory cells. There's a mononucleated cell here, and then there's two binucleated cells side by side. Likely Hodgkin's. No granulomas so far. Could it be reactive? Unlikely, right? So more of these RS-looking cells, and again, the background is all inflammatory. So we have the cell block now. This is the cell block. Again, you see a lot of these inflammatory cells with eosinophils in the background, and there these RS-looking cells here, 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 here. So the immunos that we should be doing on this. So yeah, CD30, obviously this is CD30. It's very nice Golgi staining in these large atypical cells. And besides that, PAX5, what else? CD15, LCA, anything else? EBER? And what else? LMP1, okay. Well, this is PAX5. And as you can see that we have very weak nuclear staining in these atypical cells, RS cells. There was CD15 done in them, and CD15 was also very nicely positive with Golgi type staining. CD20 was negative in these cells, and it was given a diagnosis of recurrent Hodgkin's lymphoma. And the patient obviously was put on second-line chemotherapy for this. So this is one example. Let's look at the next example. This is a 14-year-old male with pancreatic head mass. EUS FNA was done. So adequate, I guess, right? Looks malignant or benign or can't say. More pictures. हाँ जी. So what kind of cells are you seeing here? Maybe in this area, some molding थोड़ी नजर आ रही है. कोई papillary सा architecture भी है. Okay, let's look at the further high power view. Some molding here. इसमें है कुछ papillary सा architecture या नहीं? There is. Okay, so what are we thinking so far? Solid pseudopapillary. ठीक है. All right. Pap stain भी देख लें. This is the pap stain. इसमें भी नजर आ रहा है papillary architecture. नहीं है. Okay, तो इसमें फिर further high power view. कुछ molding थोड़ी सी है. कुछ rosetting सी हो रही है, right? इधर भी. So change of neuroendocrine. अच्छा. So what are we thinking? I mean, अभी तक solid pseudopapillary भी आया, फिर neuroendocrine भी आया. Obviously, those two tumors are in each other's differential all the time, right? तो क्या immunos करना चाहेंगे? This is the cell block. कुछ इसमें papillary architecture लग रहा है? नहीं लग रहा. ये है cytokeratin. Positive, negative, weak, negative. फिर solid pseudopapillary में positive होगा, negative होगा. नेगेटिव होगा. So, अभी तक तो हम फंसे हुए हैं. हाँ जी. ये जी कैम पॉजिटिव नेगेटिव. सो फोकल पॉजिटिव. कुछ थोड़ा बहुत कुछ ग्रैन्युलर सी पॉजिटिविटी आ रही है, राइट? तो क्या लग रहा है अभी तक? न्यूरोएंडोक्रिन. So we have synaptophysin now. It's very nicely positive, isn't it? अच्छा. And CD99 इस पे कराया था. CD99 was flat negative. Beta catenin was also negative. Chromogranin was also done, and this was also very nicely positive in that. So this was reported as neuroendocrine neoplasm on cytology, and final जो histology थी Whipple's के ऊपर, it turned out to be neuroendocrine tumor grade 2. So that's where all that थोड़ा सा जो atypia आपको और molding वगैरह नजर आ रही थी. So as I think Dr. Ali was mentioning in the morning, Ki67 on cytology and cell blocks. We do that, and we have a study published on that as well, in which very few cases we did, and it did help us. But what is your opinion on that?
In the pancreas, if it's a clean cell block, it would be quite accurate, but if it is significant contamination by lymphocytes or GI, then it would be quite misleading. Is that the question?
Yes. So normally you would go ahead and perform.
Yes.
Yeah.
It's always asked for muscle grade.
Great.
If
Okay.
we cannot grade because of those reasons, we say so in our report that it cannot be graded.
Right. Okay. So yeah, so in this case we did not, but I'll show you the study that we have on that, in adults obviously. This is an 18-year, another case, case number 3, 18 years old female with a pancreatic body mass. This is more clear, isn't it? अभी तो बड़ा पेनक्रियाट वो पेपिलरी लग रहा है, isn't it? फिर कुछ थोड़ा सा दोबारा सोचना है या चलूं आगे? हाँ जी. बेटर. अभी वो एग्जांपल्स जो डॉक्टर अली ने दिखाई थी, राइट? हाँ जी. थोड़ा और बेहतर. कुछ चेंज ऑफ हार्ट या स्टिल द Same. Still the same. Okay, this is PAP. Almost similar. Slightly high power view. Cell block. Could be neuroendocrine. Still can be. फिर क्या किया जाए? This is synaptophysin. क्या ख्याल है? Negative, positive. तो ये किस में पॉजिटिव आ रहा है जो आइलेट्स में? राइट, सो मेजर जो ट्यूमर सेल्स हैं उसमें वो नेगेटिव है. दिस इज बेटा कैटेनिन. Didn't do much. It's more membranous, isn't it? But then we have CD99. So it's a beautiful dot-like positivity, right? So synaptophysin negative, CD99, chromogranin भी हमने किया था, वो भी negative था इसके अंदर. So this was a example of solid pseudopapillary tumor. Okay, so like I said, we've published many articles, but the first data that I have for pediatric is what I just presented. These are some of the articles that we've had, and this is related to the PET CT, that what really looks like cancer may not always be so. And this is data that we had from 2009 to 2012. We had 87.8% adequacy. Again, if you see the number of passes is almost the same as we have in pediatric population. Majority were subcarinal nodes. And in these, the data, 36.5% of the patients with PET CT positive lymph nodes, they actually, जिसमें past history थी neoplasia की and malignancy की, they were turned out to be a benign lesions. And then USFNA के ऊपर, they were either reactive or granulomas. And those were actually reactive nodes जो हैं वो PET CT के ऊपर avid आना was something very interesting that we noted in this study for the very first time. Is this something that you see, Dr. Ali, and your having reactive nodes coming out positive on PET CT?
Yeah, actually, we also had a couple of examples of Castleman disease, incidental finding brightly lit on that.
So yeah, so this is something that we learned during that study actually. Then we had the example of neuroendocrine neoplasm, in which we actually did Ki67 in about 6 cases for definitive grading. And so there were 25 cases in this study. 21 were grade 1, 2 were grade 2, and 2 were grade 3. And there were some syndromes associated with 2 of the cases. One was MEN1 and one was von Recklinghausen's syndrome. This is again from 2015, the data of almost 5 years with regards to rapid on-site evaluation and ancillary studies. And in this, we had about 393 cases. Again, 2.2 is the average number of passes that we had, 94% adequacy, 99.6% sensitivity, and 100% specificity for our cases. And these were mediastinal nodes 46% of the times. So most common diagnoses that we had were granulomata, followed by adenocarcinomas, and then the reactive nodes. So again, we see a lot of these granulomatous inflammation, first because probably TB is so rampant in this part of the world, and then because of their immunocompromised status and being on chemotherapy, they are amenable to developing MTB. And quite a few of these actually were positive on cultures as well. This is the study, the latest one that we had in 2020. And this had almost 12 years data in there, 1,059 patients. Again, the adequacy was 91.4% with a sensitivity of 95% and specificity of almost 99%. And the diagnostic accuracy of 95.6%. And the most common site for these were pancreas for this 12 years data. And the major diagnosis that we had was adenocarcinoma in 69% of the cases. So these are the studies that we have so far for Adults, we're working on the pediatric data that would hopefully come out very soon. And then there's another study that we're currently doing, or actually in the process of publication for ERCP, I think, that is currently being worked upon. So, in conclusion, I would say that it's a minimally invasive and a very cost-effective procedure. Although, like I said, the fear factor is there, with, as Dr. Ali said. It provides access to the radiologically inaccessible sites, and the rapid on-site evaluation truly helps with a greater yield and quicker diagnosis. So do make sure that wherever you're doing that, you have a cytopathologist present alongside gastroenterologist, because that is the way to go. Because otherwise, if you don't, then it's a problem. All right, thank you very much. Is there any questions?